Good evening, dear students. This is Dr. Rajesh Kaushal here, taking care of anatomy in PrepLadder. And today we are supposed to discuss some of the recall questions which came in INI-CET exam yesterday, November 2023. And the very first question which we are looking at is asking us about the structure which has embryological derivation from the arrow marked region. I'm looking at the chat also. Saf, hi. Mark 36. Hello, good evening. So, as you see, what we are looking at is basically a transverse section of the developing baby. This is the neural tube. And then we can also see, along with the neural tube, this is the notochord, axial mesoderm. If this is the axial mesoderm, on the side of that will be the paraxial mesoderm. So basically, the examiner is asking us about the paraxial mesoderm. Earlier, INI-CET exam only, they had marked another structure, another region basically, that was dorsal and lateral to the neural tube. That time, it was asking neural crest cells. So that was a question on neural crest cell, but this time, same diagram, but they have changed it. And now they are asking for what is called as intermediate mesoderm. Before I proceed further, आपका LRR का पहला क्वेश्चन था, बिल्कुल सही है। ये तो अच्छी बात है कि जो पढ़ा रहे हम वही आ जाता है। आप लोगों की दुआ है, भगवान की दुआ है, मेहनत भी है। एक ही बात कहूंगा कि प्रीवियस ईयर क्वेश्चंस को प्रैक्टिस करते रहिए, वही उसी से बेड़ा पार हो जाएगा। क्वेश्चंस आते हो ना आते हो, टॉपिक्स आते हैं। So, as we see, this is the diagram we are talking about. And here you can understand, in the developing baby, when we look at the layers, 3 germ layers after gastrulation, dorsal is amniotic cavity, ventral is yolk sac cavity. The dorsal layer which we focus upon is the ectoderm. In the middle, we'll have the mesoderm, and then the more ventral will be endoderm. So this time the examiner is focusing upon mesoderm. As I mentioned, this is the axial mesoderm, the notochord. On the side of that will be paraxial mesoderm. So this is the notochord, axial mesoderm in the axis, and then paraxial mesoderm. So examiner was actually marking this region and asking us what is coming from here. Now, if this is the paraxial, this is axial, this is paraxial, what is still more lateral? This is lateral plate mesoderm. Here you can mention lateral plate mesoderm, not only this side, but also that side. And between the lateral plate and the paraxial mesoderm, this is paraxial, is the intermediate mesoderm. This is intermediate mesoderm. So this is the region of intermediate mesoderm. Basically, we can draw this diagram ourselves also. Let me draw it to simplify. Say we are drawing a diagram, transverse section of the embryo after gastrulation. Dorsal layer is ectoderm, middle layer is mesoderm, the ventral layer is endoderm. In the mesoderm, we have axial mesoderm, which is also called notochord. Then we have paraxial mesoderm. This is the paraxial mesoderm. Then we have the lateral plate mesoderm. This is the lateral plate mesoderm. And between the two, you can see here, will be the intermediate mesoderm. So this is intermediate mesoderm. Now, once you have that orientation, let us go back to the question, what the examiner is asking us for. You should know here the derivatives also, like if you are talking about paraxial mesoderm, which is here, this region, is going to give us somites, and somites will give us some derivatives. One of them is sclerotome. And sclerotome is going to form vertebra. Not only vertebra, but attached to that is the ribs. So vertebra plus ribs. The notochord is here. This is the notochord. This is paraxial mesoderm. Paraxial mesoderm forms somites. Somites will form certain structures like sclerotome. Sclerotome will form vertebra, and associated with that is rib, basically axial skeleton. So this is paraxial. What is the intermediate mesoderm giving? Intermediate mesoderm is giving us genitourinary system like kidney, testis, ovary. So intermediate mesoderm give the genitourinary system like kidney, testis, ovary. What is lateral plate mesoderm here? Lateral plate mesoderm will have several derivatives, but one thing which you can mention here is the upper limb, lower limb skeleton. That is upper limb, lower limb, appendicular skeleton. So remember that appendicular skeleton, upper limb, lower limb, humerus, femur, all those bones, they do not develop from paraaxial mesoderm. They develop from lateral plate mesoderm. And if you talk about the vertebra and ribs, they come from paraxial mesoderm. Then there are some neural crest cells also. As you talk about the neural crest cells, they'll be developing here. And these neural crest cells, they are migratory and they can give you a lot of things. One of that is peripheral nervous system. Peripheral nervous system like ganglia, like dorsal root ganglia. With that information, you can go back to a question. And you see, this is your question. It is asking us about the arrow mark region, which is paraxial. This is axial, this is paraxial, means the somites, means the sclerotome, means the vertebra, means the ribs. So your answer is ribs. Choice number C is your answer. What about the kidney? Kidney will come from kidney, testis, ovary will come from intermediate mesoderm. And what about the dorsal root ganglion? Dorsal root ganglion is peripheral nervous system, will come from neural crest cells. And what about the parietal pleura? Parietal pleura and visceral pleura, they both come from lateral plate mesoderm. If it is dorsal, then it will form parietal. If it is ventral, then it will form visceral. So pleura has two layers. If parietal, peripheral, then it will come from dorsal, lateral plate mesoderm. And if it is visceral pleura, then it will come from ventral portion of lateral plate mesoderm. The diagram which we have drawn, there you can see. Let me show it there also. If we are looking at this diagram, what I'm telling is, this lateral plate mesoderm will have two portions. There is a dorsal portion forming parietal pleura, and this is the ventral portion because yolk sac is ventral. This is ventral portion of lateral plate mesoderm. It will form visceral pleura. Ventral forms visceral pleura. So ventral, visceral, dorsal, parietal pleura. I hope this will help you. So part of diagram is not coming in camera field. Which part is not coming? Okay, so that means it is a little bit zoomed. Okay. Should I keep it in the center or center? Okay, so now moving on to the next question. See, this is one of the diagram which came, and it is asking us about which of the following statement is incorrect regarding the anomaly shown in the photograph. So the anomaly which is shown in the photograph is sacrococcygeal teratoma, and sacrococcygeal teratoma or oropharyngeal teratoma, teratomas, come from primordial germ cells. Some books will say primordial germ cells come from epiblast, so maybe it is coming from epiblast. So teratomas are basically coming from primordial germ cells, first answer. If not found, then they may be coming from epiblast in the primitive streak. You know, primitive streak develops by proliferation of epiblast. So it is the epiblast cells. Again, I think we are going out of focus. So epiblast will proliferate to form primitive streak, and epiblasts are again migratory cells. They will form primordial germ cells, which are again migratory. Let me show you a diagram, then it will become more evident. But the thing is, if it is a sacrococcygeal teratoma, what about these statements? Is it a precaudal plate anomaly? No. Why it is not a precaudal plate anomaly? Because precaudal plate is towards the mouth. It could be oropharyngeal teratoma. So oropharyngeal teratoma is related with precaudal plate, not the sacrococcygeal. Sacrococcygeal is caudal, and precaudal is more cranial. So maybe oropharyngeal teratoma related to precaudal plate. It is not an anomaly of that, basically. So is it resulting from aberrant migration of primordial germ cell? Yes, that is what we mentioned. Is it a benign tumor of coccyx? It is at the base of the coccyx, and most of them are benign. Some of them are malignant. So mostly because they are benign, you can take it as benign, though it is not exactly a correct statement. But you have to find one wrong statement. So twice A is already your answer. And presence of teeth and hair. Yes, presence of teeth and hair, because it is coming from epiblast. Epiblast form all the three germ layers. So it will have all the three germ layers: ectodermal derivative, mesodermal derivative, endodermal derivative. It can have gut tube, it can have heart, it can have brain. So brain tissue can be there. And if you're telling teeth and hair are basically, teeth is from neural crest cell lined by surface ectoderm, odontoblast, and then ameloblast. So neural crest cell form the teeth covered by surface ectoderm, and hair is, of course, ectoderm, surface ectoderm. So it can have all the three germ layers. No problem with any of the choices, but choice A is wrong. That is your answer. Let me show some other details. Like here, you'll find, yeah, it's better I stay in the center. My diagrams stay in the center because some zoom, I think I can take care of that zoom. Now, how's it coming? Little bit to one side. How is it coming? This is my studio, so I arrange everything. Nobody is here. Door is locked. Camera, UPS, everything, lights. Nobody should interfere. Anyway, so what I'm telling is, you have to understand the end of second week. And see, the point is, questions do not repeat, topics repeat. And INI-CET exam people, they know that once they ask a topic, they'll keep digging deeper, 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 and around the topic. So our job is, once we get the question, we should go around the, improve our sphere of activity. Whatever is related with the question should be done, so that next time if the question comes in a deviated way, we should be able to handle. That's the point. So week number 2, by the end of week number 2, these primordial germ cells, which are derivative of epiblast cells, forming the primitive streak. So by the end of week number 2, as primordial germ cells will appear in the epiblast, in the primitive streak, they start migrating. They migrate to the endodermal wall of yolk sac, and they reach the endodermal wall of yolk sac week number 4. Statement by Langman embryology, and questions come like that. One more thing I'll tell you. This exam has proven that they can ask you questions from the last 15 years. Normally people used to say, tell that do the last 5-year questions. INI-CET people usually ask last 5-year questions. But this time, they have asked from last 15 years, actually 20 years. Because I'm in the system for last 20 years, I know. Most of the questions they've asked are repeat questions, repeat topics. So these are, and I teach them in my class, despite knowing that nobody's asking, still I teach. Why? Because I know they will ask these questions. Questions can come 10 to 15 years prior, which were asked now, with a modification, a different taste. Okay, anyway. So, week number 4, the primordial germ cell will come to the endodermal wall of yolk sac, endodermal wall of yolk sac, and then they migrate towards the genital ridge. In the genital ridge, they will be populating gonads like testis, ovary by the end of week number 5. So be careful. Week number 2, primordial germ cell formed. Week number 4, they are in the endodermal wall of yolk sac. By the end of week number 5, they are in the genital ridge, maybe testis or ovary, and they populate the testis or ovary or the gonads. But there can be problem in the migration, aberrant migration. If there's aberrant migration, there'll be problems. Like if they migrate towards the tail of the baby, if they're migrating towards the tail of the baby, then there can be sacrococcygeal teratoma. And if they're migrating towards the oral region or procaudal plate, as the question had, it can form oropharyngeal teratoma. This all we teach in the class. The point is, the problem is, students, they want to take shortcuts, ultra shortcuts, rapid revision, rapid revision, but that doesn't work because our classes themselves are shortcut. If the regular class is shortcut and I make ultra shortcut to make rapid revision, and you want rapid revision means ultra shortcut, one day we'll have to suffer. So it's better go the long way. Shortcuts sometimes may help you, but if you are stuck, then you are stuck for a long time. So this is what I'm talking about. So my advice is always, you can use your rapid revision for rapid revision, but the regular course should be attended. So this is oropharyngeal teratoma, which is again 3 germ layers can be there, and aberrant migration of primordial germ cell, cephalic. And this is sacrococcygeal teratoma. From the genital ridge, the primordial germ cells have reached here. Anyhow, what about this question? These are all questions which keep coming, but in different ways. Like this time they are asking, apocrine glands are commonly present in which region? See, apocrine sweat gland, basically, apocrine sweat glands. So apocrine sweat glands are commonly present in which region? See, most of the glands in our body are acrine, which are also called merocrine. So merocrine or acrine sweat glands, these are more common. And mostly example is palm and sole. So if you say acrine, merocrine, palm and sole, scalp, face, but not the axilla. In fact, axilla will have acrine and merocrine, but question is asking apocrine sweat glands are found here. See, if you ask me acrine or merocrine, they are present in all of them, but that is not the question. Question is where you are finding apocrine. Apocrine are specifically present in the ceruminous gland, modified apocrine sweat gland, ceruminous gland, wax gland. In the ear, you have cerumen, wax. So ceruminous gland in the ear is modified apocrine sweat gland. Number 2, mammary gland. Mammary gland is modified apocrine sweat gland. These 2 examples always we discuss. Number 3, apocrine sweat glands are found in the axilla and perigenital area. Axilla and perigenital area. So, of course, your answer here is axilla. That should be your answer. Choice number C should be answer because they're asking for apocrine. Remember, in axilla, you have both merocrine plus apocrine. And some more details. This is a question came in year 2005, AIMS question. INI-CET, who is conducting INI-CET? INI-CET is conducted by AIMS people, assisted by JIPMER people, PGI Chandigarh people, and that is why multiple answer questions, because PGI Chandigarh people have come and joined the team. So it's better you do last 20 years AIMS question, PGI Chandigarh question. Means INI-CET people, AIMS people, they have a tendency, they keep changing the pattern of the exam. I have seen that because I have been teaching for last 22 years, started teaching in 2001. I have seen all their colors and it's like गिरगिट की तरह रंग बदलते रहते हैं. जिसने गिरगिट को देखा हो कि वो जब सरफेस बदलता है, जैसे टाइम स्लॉट बदलता है, वो अपना रंग बदल देता है, वैसे ही INI-CET वाले रंग बदलते हैं. तो आपकी नजर काफी दूर तक होनी चाहिए अगर आप उनकी तैयारी करें. वैसे कंपटीशन है तो कंपटीशन में तो अगर आपने आंसर नहीं किया तो किसी और ने भी आंसर नहीं किया तो कंपटीशन रहा ही नहीं ना. कंपटीशन तब है जब किसी ने आंसर कर दिया और आपने नहीं किया. जब किसी ने करा ही नहीं तो कंपटीशन खत्म. Net zero effect. Anyway, previous year questions are very important. Now, as you see, this is one diagram which जो अभी आपने कहा ना LRR, ये सब LRR में था कि नहीं था बताओ. ऐसे ये बोलूंगा तो फिर स्टूडेंट बोलेंगे कि था तो फायदा क्या हुआ, हमने तो आंसर नहीं लगाया, फिर फायदा क्या हुआ. फायदा होता क्या है, एक बार पढ़ने से याद नहीं, 2 बार रिवाइज करना होता है, कम से कम 3 बार पढ़ना, और वो भी 1 महीना भूल जाओगे, उसके बाद फिर 1 बार रिवाइज करना होता है. जब मैं भूल जाता हूं तो आपकी बिसात क्या है, मैं ही भूल जाता. सर आप ही भूल जाते हैं तो फिर आप पढ़ा कैसे रहोगे, क्योंकि मैं फिर रिवाइज कर लेता. जब आपका टीचर रिवाइज कर लेता है तो आप कहेंगे सर आप तो एक ही सब्जेक्ट आपके पास, उसको रिवाइज करते रहते हो, हमारे पास 19 सब्जेक्ट है, उनको हम कैसे रिवाइज करें. सेम डिस्कशन. क्या करें भाई, बता, वही बार बार पूछते हैं ये लोग. So the thing is, see, eccrine sweat glands, most commonly the sweat glands in our body are eccrine, which is also merocrine, and they will be opening directly on the surface of the skin. Watery secretion on the surface. But if you're talking about the, let us take some other color. This. If you're talking about the apocrine sweat glands, number one, they are very few, like ceruminous gland, mammary gland, some glands in axilla and perigenital area, apocrine. Apocrine, they have thick viscous secretions. And that is why, you know, in axilla, those viscous secretions can be populated by bacteria and bad smell. That bad smell comes because bacteria is populating the sweat which came, this thick viscous sweat, by apocrine sweat gland. That bad smell if you don't take bath for a day or 2. So apocrine sweat gland, their secretions are thick viscous and they don't open on the surface, they open near the hair follicle. So secretion will come along with the hair follicle. These are some questions, again, they can be asked. So apocrine sweat glands are few and they don't open on the surface. They have thick viscous secretion. They open into the hair follicle, along the hair follicle, along with the other gland, which is this one, the holocrine sweat gland, sebaceous gland, which is holocrine. So sebaceous gland is holocrine. Some sweat glands are apocrine, and most of the sweat glands are eccrine. Like, you know, these type of questions come. This is what they ask normally. So as you see, if you are telling that it is merocrine, no loss of cell membrane and secretions just poured into the lumen. Most of the sweat glands are merocrine. Some sweat glands are apocrine. Apical portion is pinched off and covers the secretion. A part of cell membrane is broken and covers the secretion, so forms bleb formation. Loss of cell membrane is there. Apical loss of cell membrane, that is why apocrine. And holocrine is whole of the cell is disintegrated and becomes the secretion, like sebaceous gland. Sebaceous gland, all the cells, organelles, they break up and form the sebum. So holocrine means whole of the cell is destroyed, becoming secretion. Apocrine means apical part of the cell membrane is lost and covered the secretion. And merocrine, there is no loss of any cell membrane. These are all histological questions. Anyhow, now as you come back to This question you already have known: apocrine, axilla, perigenital area. That should be answered. Now, moving further, look at this question. They were asking us about the arrow mark region. This arrow mark. Now, the thing is, sir, we do PGI and chapter questions also. I won't recommend because that will be too much for you. At least AIMS questions. At least AIMS questions. See, the thing is, I write a book by the name Self-Assessment and Review of Anatomy. If it was not needed, why should I be writing the book? You will see whatever questions came, they are all in that Self-Assessment Review of Anatomy. We ourselves don't want to teach you too much. We give you capsule course. But still, why we are writing that book? Why the short notes which are available, like rapid revision notes or the main notes, why should I write that book? Now you understand, in that book you'll find these details, but we are not teaching them in our regular classes. They are not in the rapid revision notes at all. So there's a purpose of everything what we do because of our experience. Cannot talk too much about that, but here, I think, was this the question or not, first of all? You not me, very simple. Yes, that book was also good. Now that has transformed itself. So I think this was a question. They are asking, identify the arrow mark structure and asking intrapulmonary bronchus, terminal or respiratory or alveolar sac. First of all, your eyes should be trained in the first year. By fifth year, we forget everything, obviously. But your eyes should be trained to find that this is alveolus. These are alveoli. But once you know these are alveoli, this is lung. And anyway, the choices will tell you that they're talking about something about respiratory, H&E stain, respiratory system. Now, this has a thick wall. This has a thick wall. And even you can see some lymphoid tissue. Bronchus associated lymphoid tissue, BALT, mucous associated lymphoid tissue, bronchus associated lymphoid tissue. You can also see some cartilage here, not very clear to you maybe. The diagram shows some cartilage here. This is some cartilage. If it is cartilage, it should not be in the bronchiole. And if it is in the bronchiole, maybe it is the last bronchiole. And which is the last bronchiole? That is terminal bronchiole. So they were asking for terminal bronchiole. How do you know this is terminal bronchiole? Some students told that some cilia was evident. And if cilia is evident in terminal bronchiole, cilia very rarely you will find in the respiratory bronchiole, and this not at all. So my answer is terminal bronchiole. Why? Why not intrapulmonary bronchus? Bronchus. If it is bronchus, you'll have a lot of cartilage. But here you don't see a lot of cartilage. You see just island of cartilage. So there are a lot of things which you can tell, but to give you, see, answer is terminal bronchiole. That is my answer. And some details here as we teach. What we should know is trachea becomes, bronchus becomes bronchiole. That is how it goes. There's a conducting portion, and then there is a respiratory portion. So this is just for conduction. Respiratory means respiratory gas exchange will happen. So respiratory gas exchange, where happens? Where you have alveoli. Where alveoli begin? In the respiratory bronchiole. Respiratory bronchiole is the first one, which will be communicating with the alveolus. So that is respiratory portion. Before that, terminal bronchiole or bronchus or trachea, they are conducting pathway. Now, respiratory bronchiole will become alveolar duct, will become alveolar sac, will be communicating with alveoli. But alveolus is communicating with respiratory bronchiole also. Respiratory gas exchange takes place at the level of respiratory bronchiole also, because it is in communication with alveolus. So respiratory bronchiole, alveolar duct, alveolar sac, alveolus, this is a sequence. Here you see the epithelium. Normally we have pseudo-stratified ciliated columnar epithelium with goblet cells. Pseudo-stratified ciliated columnar epithelium with goblet cell. But the goblet cells, they reduce in number and almost disappear in the bronchiole level. They can be there in the bronchus trachea. So goblet cells, they are almost non-existent in the terminal bronchiole or respiratory bronchiole region, though they will be present at random places. If you're talking about a cilia, cilia will also reduce. See, cilia moves what? The mucus. If the mucus is not being secreted by goblet cell, you don't need cilia, but they encroach a little bit further, and you can find that cilia are present not only in terminal bronchiole but also respiratory bronchiole. So terminal bronchiole, respiratory bronchiole can have cilia, but if you have to choose between the two, I'll go for terminal bronchiole. Will have cilia, and respiratory bronchiole may have cilia. Another thing is, you see, look at the epithelium. Terminal bronchiole, it becomes simple columnar, and respiratory bronchiole, it becomes simple cuboidal. So chain of epithelium also. Pseudo-stratified ciliated columnar epithelium with goblet cell. The goblet cell and cilia are reducing. The height of the cell is also reducing. In terminal bronchiole, you have columnar cells. In respiratory bronchiole, you have cuboidal cells. What cell you have in the alveolus? Most of the alveolus is covered by type 1 pneumocyte, and type 1 pneumocyte is flat epithelium, that is squamous. So the columnar cells becoming cuboidal, becoming squamous. That is a change. And hyaline cartilage, if you talk about hyaline cartilage, you see it is also reducing. And hyaline cartilage should not be there in bronchiole. That is the rule, basically. But randomly you can find some place, like we saw in terminal bronchiole, you can randomly have the cartilage. If somebody asks us, hyaline cartilage stops at which level? You should say it should stop at the bronchus level. The hyaline cartilage should not be in the bronchiole, though it may be randomly present. So these are some of the features which can help us. Anyway, coming to the diagram proper, this was the diagram given to us. And I'll repeat the information once again. Say, this is terminal bronchiole, this region, that is the arrow mark they were asking. This is lymphoid tissue, a lot of lymphocytes, mucosa-associated lymphoid tissue. This is a blood vessel here. This is a cartilage, C cartilage, C cartilage. And this is respiratory bronchiole. This is respiratory bronchiole. This is respiratory bronchiole. So basically, terminal bronchiole opening into 1, 2, 3 respiratory bronchiole. And if you go still further, you will see this is terminal bronchiole. It does not communicate with alveolus. That is how you identify it. It is intact wall, doesn't communicate with alveolus. It is terminal bronchiole. But if it is respiratory bronchiole, it will be communicating with alveolus. Can you see the breaks here? There are breaks. So it does communicate with the alveolus. That is a difference. Terminal bronchiole will not communicate with alveolus because it is conducting pathway. And respiratory bronchiole will communicate with alveolus because it is respiratory pathway, respiratory portion of the lung. And it is opening into alveolar ducts. And alveolar ducts opening into alveolar sacs, and alveolar sacs opening into the alveolus. Why I'm teaching you all this? Because next time, maybe in the NEET PG, they'll ask you deeper than what they already have asked. Okay. Now, there was a question. Sir, the slide shown in our exam was respiratory bronchiole. If it was respiratory bronchiole, it should not have cilia. And it should be communicating with alveolus. Was it like that? Ankit, it was zoomed to 10. Clear white space. Cartilage was not there. Okay. It was communicating. If the bronchiole was communicating with the alveolus, it is respiratory bronchiole. You're correct. And if it is respiratory bronchiole, it may have cilia. So shouldn't have cilia, but may have cilia. Again, if you look at the respiratory bronchiole, let us say this is respiratory bronchiole. Let me rub this off, and then this is respiratory bronchiole. First of all, respiratory bronchiole should communicate with alveolus because it is helping in respiratory gas exchange, number one. Number two, the cells will be cuboidal. Cuboidal. How do you know it is cuboidal? I know it is cuboidal because central spherical nucleus, height equal to breadth. Though to say it is very easy, to look at and find is difficult, but you can differentiate it with this. Let me just zoom this if possible, and you can see the difference between the two types of cells. Do you notice one thing here? These cells, central spherical nucleus, and their cell boundaries are very height equal to breadth. It is like this. But that you don't see here. Can you see oval basal nuclei? And cell boundary is here. So these are columnar. Your eyes should be able to identify how a cuboidal epithelium differentiates itself from a columnar epithelium. This is columnar. If it is columnar, terminal bronchiole, and no communication with alveolus, terminal bronchiole, cilia present. So simple columnar ciliated without communicating with the alveolus is terminal. Respiratory means it will be communicating with the alveolus. It will be cuboidal cells, and cilia may or may not be there. I hope this helps. Type 2 pneumocyte will be present in alveolus. It will be in the alveolus. क्या है? Breaks था, alveolar था, बीच में bronchiole showed the functional unit. Picture quality was 144p and my desktop was हमारे देश में जो है सिस्टम पहले बन जा, मतलब रूल्स पहले बन जाते हैं, सिस्टम बाद में आते हैं. कंप्यूटर बेस्ड टेस्ट दे दो और कंप्यूटर ही नहीं है वहां पर. भाई देखो, ये तो बर्दाश्त करने वाली कहानी है, हमें बर्दाश्त करना ही पड़ेगा. हिंदुस्तान में रहोगे, फायदे भी हैं, नुकसान भी है. अच्छा, ऐसा कोई क्वेश्चन था? डिड यू हैव एनी सच क्वेश्चन वेयर they were showing islet of Langerhans when asking for alpha, beta, delta cell? Was there a question like that? Which will be too much actually. So islet of Langerhans, alpha, beta, delta cell, did they ask? इस पर मुझे काम करना पड़ेगा, अभी नहीं डिस्कस करेंगे, बाद में करेंगे. हो गया काम. ये देखो, शिवानी बंसल कह रही हैं यस, डॉक्टर ग्लूटियस कह रहे हैं यस. डॉक्टर ग्लूटियस पहले खूब सारे आंसू उनके निकले, जो मेरे भी निकल रहे हैं ये देखकर कि ऐसे क्वेश्चन. ये तो भाई फर्स्ट ईयर में भी आप नहीं पता कर सकते, फाइनल ईयर में तो क्या ही पता करेंगे. मतलब एक बात बताया तो INI-CET वालों को बहुत जोर से धक्का लगने वाला है जब वो देखेंगे कि एनाटॉमी के जितने क्वेश्चन पूछे थे उसमें 50% तो किसी ने आंसर ही नहीं करे. सही आंसर तो करे पर सही, तो उनको समझ में आएगा भाई ये हमने कुछ ज्यादा एक्सपेक्टेशन कर दी अपने बच्चों से, थोड़ा सा नीचे करो, स्टैंडर्ड को थोड़ा नीचे, बहुत ज्यादा है. तो हंसी आ रही है. देखो, जब दर्द बहुत ज्यादा बढ़ जाए तो चेहरे पे मुस्कुराहट आ जाती. ऐसा मत समझो कि ये हम हंस रहे हैं तो मतलब कोई, ये दर्द वाली हंसी है, आपने देखा होगा किशोर कुमार जब गाना गाते हैं, दर्द वाला गाना भी मुस्कुराते हुए गाते हैं, मतलब दर्द इतना था कि हद से बाहर चला गया। तो अब क्या, व्हाट डजंट किल यू मेक्स यू स्ट्रॉन्ग। एनीवे, यू हैव टू जस्ट एक और बताओ, क्या ये क्वेश्चन था? डिड यू हैव दिस क्वेश्चन? बताओ बताओ भाई, जल्दी बताओ। मैं ज्यादा ही समय ले लेता हूँ बाकियों की तुलना में, पर जरूरी है। अगली बार जो एग्जाम आ रहे हैं, द नेक्स्ट एग्जाम, कमिंग एग्जाम्स, नीट, maybe somebody is preparing for NICT, these are very important. So tell me please. Yes, yes, this I have taught in PrepLadder rapid revision, thinking that someday they will ask. I thought someday they'll ask, and they have asked. Now what they have asked, I don't know, but somebody told me that they gave adrenal gland histology and adrenal gland gross anatomy also, and in surgery also adrenal tumors were there. So they are now after adrenal. Anyway, so this is adrenal gland. How do you identify it? It will be a long discussion, but the thing is, see, this is the capsule here, and you'll have GFR. What is GFR? Glomerular filtration rate. No. This is fasciculata, glomerulosa. This is glomerulosa. First of all, glomerulosa, fasciculata, and reticulata. So G is glomerulosa, bunch of cells, glomerulus, and then fasciculata, fascicles. Can you see bunch of cells? Glomerulus, like kidney glomerulus. So glomerulosa, fasciculata, like fascicles, and reticulata means reticulum, like a network. So like a reticulum network. So GFR in the adrenal cortex. If this is the area, this is medulla. You know what medulla, adrenal medulla has? Neural crest cell derived sympathetic neurons. And if these are neural crest cell derived sympathetic neurons in the medulla, what do they secrete? In the medulla, they will secrete epinephrine, norepinephrine. So epinephrine, norepinephrine in the medulla. Now, what is the G secreting? Glomerulosa. Glomerulosa is secreting mineralocorticoids like aldosterone, renin, angiotensin, aldosterone system. So G glomerulosa, the mineralocorticoids. The fasciculata is giving us glucocorticoids like cortisol. Emergency situation, you are in a war, some shooting is going on, you get a bullet, but you don't feel the bullet. You just keep fighting. Why? Because your adrenal cortex giving you cortisol. It will help you tide over the emergency. Along with that, adrenal medulla will be giving you epinephrine, norepinephrine. So epinephrine, norepinephrine from the medulla plus cortisol from the zona fasciculata will help you continue the fight, despite the fact that you must have seen in some movies 4 or 5 bullets. Still the hero is, because he's a hero, he keep on charging towards the villain. How come? 1, the epinephrine, norepinephrine. 2, the cortisol, emergency. In emergency, it works. And what about the reticularis? It is actually giving sex steroids and basically DHES and all that, weakly androgenic hormones. So I think this must have been the question. And then a student will have to work upon this topic later also. Some student gave this diagram, and they are telling that there was an arrow mark upon these cells also, interstitial cells of Leydig. Was this question there? It means the last 3 years, INI-CET people are after histology, H&E slides now. Before that, they were after gross anatomy dissected specimen. Before that, they were after dissected specimen of brain. So 6 years back, dissected specimen of brain. 3 years back, dissected cadaveric images. And now last 3 years, histology, H&E images. So was this question there or not? Interstitial cells of Leydig marker. Was it there or not? Anyway, if it was there, what does it secrete? Leydig cells give testosterone. If Leydig cells are giving the testosterone, then who is giving the inhibin or Müllerian inhibiting substance? That will be the Sertoli cells. So Sertoli cells will give Müllerian inhibiting substance and inhibin, which is feedback inhibition to pituitary gland for this FSH and LH, all that. So Sertoli cells are within the seminiferous tubules. Large cells within seminiferous tubules. So this is the seminiferous tubule here. And within the seminiferous tubule, you will have the Sertoli cell giving inhibin and Müllerian inhibiting substance. Whereas outside the seminiferous tubule, interstitial tissue, you'll have the cells of Leydig giving testosterone. They focus on Graves area. Histology is a gray area. Yes, I know. First year, we learn less and break slides more. Slide is broken, and then the attendant will come, pay me 10 rupees because you have broken the slide. It used to happen in year 1993, Bangalore Medical College. The students, they will just somehow on the desk and slide is broken. What is your name? What is your roll number? Pay me 10 rupees. You have broken the slide. Anyway, let us proceed. Nothing to say here. You already know what is your answer. But tell me, which bone is this? Which bone is this? So they ask you even identification of bone. Tell me, which bone is this? Tell me the name of this bone. This is here. You see, it has a socket. There's a socket. A ball will come here. The stapes will come here. Stapes will come here. Incudiostapedial joint. And this is malleus, the hammer. So malleus, this is malleus. If this is malleus, this is incus. And there is no stapes shown here. But if it is malleoincudial joint, saddle synovial joint, convexo-concave, x-axis, y-axis. One axis is concave, other axis is convex. Concavo-convex, saddle synovial joint, like the first carpometacarpal joint, the externoclavicular joint. So malleus incus joint, in the upper limb, 2 are saddle. First carpometacarpal, sternoclavicular. In the lower limb, talocalcaneonavicular. So saddle, for examples you can remember, malleus incus is saddle, sternoclavicular is saddle, first carpometacarpal is saddle, and talocalcaneonavicular joint forming medial longitudinal arch. Main joint in the foot or medial longitudinal arch. Talus calcaneonavicular is also. Just a second. No. Tell me what mistake I'm making. What is the mistake I'm making here? Talocalcaneonavicular is not saddle. The CC joint is saddle. Calcaneocuboid is lateral longitudinal arch. CC joint, calcaneocuboid, lateral longitudinal arch. Because talocalcaneonavicular is ball and socket. Head of talus, ball and socket. So I'll repeat. What are the 4 examples of saddle? Malleus incus and sternoclavicular and first carpometacarpal and CC joint, calcaneocuboid joint forming lateral longitudinal arch. See, even we forget. To forget is human. So don't feel bad when you forget. You should accept that you have forgotten. It's a mistake and you correct your mistake. Life is all about correcting yourself. So it is CC joint, which is saddle, and talocalcaneonavicular is ball and socket. So give me the 4 example of ball and socket. Ball and socket 1, medial longitudinal arch, talocalcaneonavicular. Number 2, hip joint. Number 3, shoulder joint. Number 4, stapes and incus joint. So incus and stapes is ball and socket. The ball is ball and socket joint in the aerocycles, but they're synovial. They're synovial joints. So, for example, so ball and socket, incus stapes, and shoulder joint, hip joint, and calcaneonavicular joint. Zoom out. अच्छा, एक सेकंड ये मैं अभी कर लेता हूँ। ये इन्होंने फिर जूम इन कर दिया लगता है। मैं यहाँ से जूम आउट कर रहा हूँ, वो जूम इन कर रहे हैं वहां से, दो जगह से कंट्रोल। अब मैं आउट ऑफ व्यू हो गया क्या? मैं दिख रहा हूँ कि नहीं दिख रहा? अब तो दिख रहा होगा। एनीवे, क्या आंसर क्या है भाई? आंसर तो बताओ। ये मैलियस इनकस है, सो सैडल। बॉल एंड सॉकेट के 4 एग्जांपल हमने बता दिए। इसमें यहाँ पे बॉल एंड सॉकेट, ठीक है। चलो आगे चलते हैं। देयर इज नो, दिखना है कि नहीं दिखना बताओ? फिर से जूम आउट करूं क्या? अब बताओ। यार टाइम कहाँ हो रहा है? चलो कोशिश करते हैं। जब 2 ऑपरेटर होते हैं तो यही होता है। इसलिए मैं किसी को ऑपरेट, मैंने आपसे शुरू में क्या कहा था, कुंडी बंद कर रखी, कोई अंदर ही आ सकता, पर ये एक्चुअली यहाँ से जूम से वहां पहुंच रहा है, वहां पे वो लोग अपना थोड़ा मॉड्यूलेट करते हैं। ऑब्वियसली इट्स अ टीम वर्क। अच्छा, इसका बताओ। ये तो क्वेश्चन रिपीट है, थोड़ा सा अलग है। ओके, ठीक है। रॉय द ओल्ड गेमर। ओल्ड गेमर कौन सा गेम खेलते हो भाई? अगर ओल्ड गेमर हो तब तो तुम बैटलफील्ड खेलते होंगे। बैटलफील्ड 1 2 3 4 5, या कि क्या है वो आजकल क्या चल रहा है? कॉड, सीओडी। या पबजी। पबजी खेल रहे हो तुम? ओल्ड गेमर। लेकिन पबजी तो नया गेम है। तो तुम मेटल गियर सॉलिड खेल रहे होंगे। मेटल गियर सॉलिड, लिक्विड स्नेक, सॉलिड स्नेक, टाइटन क्वेस्ट, एटर्नल एम्बर्स, एज ऑफ एम्पायर्स। वाह, वेरी गुड, बहुत बढ़िया। मैं भी खेलता था, अब टाइम ही नहीं। ओके, सो arrow marked efferents. Efferent, E is exit. Exit means outgoing. E for efferent, E for exit. Exit means outgoing. So it is sending fibers outgoing towards what? Towards which nucleus of thalamus? So it is a repeat question. I think immediately you would have answered. But the thing is, what are they marking? They are marking fornix, or they could be marking this mammillary body. So that is circuit basically. They could be marking this mammillary body, or they could be marking this fornix. So what happens is, means which nucleus they ask? Anterior nucleus. That is your answer. Anterior nucleus of thalamus. Pappage circuit. Let us look at the Pappage circuit. Yeah, Roy, the old gamer. Yes, I am also old gamer. I like games. Whenever I have time, I play games. Call of Duty, COD. Call of Duty is a good game. And I play this Hideo Kojima games. Recently, Death Stranding. Before that, Metal Gear Solid. Only if I have time. So this is something which, if I say that I keep teaching again, it will not sound good, because there might be some students who have just joined, and it might be new for them. So just you should know that Pape circuit is important. Pape circuit is about emotions. It is about behavior, but emotions cannot change the behavior until you have some memory, basically short-term memory, converted into long-term memory. And this short-term memory, if you convert it into long-term memory, your behavior will change. So emotions can change your behavior by short-term memory becoming long-term. You learn and then you change your behavior. This is all limbic system. In limbic system, Pape circuit is important. Now, when you say emotions, behavior, short-term, long-term memory, and Pape circuit in limbic system, what is this Pape circuit? What is the seat of short-term memory? Short-term memory is hippocampus. And from hippocampus, the major output tract from hippocampus in the Pape circuit, major output tract is fornix. Via fornix, you will go to hypothalamus. Hypothalamus, that is mammillary body. So you will see here, hippocampus will send via fornix. This is the fornix to the mammillary body, which is hypothalamus. And then there will be a mammillothalamic tract. Mammillothalamic tract. And that mammillothalamic tract will go to anterior nucleus. That is the question. This is mammillothalamic tract. So hippocampus is for short-term memory. You want to convert into long-term memory, use the fornix and send it the information towards mammillary body, which is hypothalamus. From mammillary body towards anterior nucleus of thalamus. So if the marker is on hippocampus or on fornix or on mammillary body, and they're asking where the outgoing fibers are going to reach which nucleus of thalamus, then you should say anterior nucleus of thalamus, and it comes back via cingulate gyrus and hippocampus. It's a neural circuit, complete neural circuit. So hippocampus, fornix, mammillary body, mammillothalamic tract, anterior nucleus of thalamus. From there, it will go to the cingulate gyrus, and from the cingulate gyrus, it will come back to the hippocampus. It'll come back to hippocampus. So 1, 2, 1, 2, 1, 2. Convert short-term memory into long-term memory, change emotions, behavior. All that is Pape circuit. And it's very important. Continuously, they are asking. Anterior nucleus thalamus is your answer. What about this question? What about this question? First-person shooting. Yes. I like the games which have first-person shooting. Even third person is okay. FPS, first-person shooting, yes. Tell me, this was the question, first of all. Was this the question? So this is inferior olivary nucleus, olive. Somehow the pyramids have been cut. This is pyramid. So this is pyramid. That is olive. And deep to olive, let me use this color only. Deep to olive, you have inferior olivary nucleus. So this is anterior medulla oblongata. Now, if these are the pyramids, that is the olive, anterior medulla oblongata, this is inferior olivary nucleus. Inferior olivary nucleus. This is olive. Deep to olive is inferior olivary nucleus. This is pyramid. Deep to pyramid will be the pyramidal tract, corticospinal tract, corticonuclear tract. So anterior medulla, but they are showing on the posterior medulla. Posteriorly also inferior cerebellar peduncle. I think they were marking inferior cerebellar peduncle. So which artery supplies that? That was the question. Reward, punishment, memory. Another question, coronal section, thalamus asking function, motor, reward. Anyone can, yeah, that I think I have a diagram. I'll show you the diagram. That is a different question. Yes. So what about this question? See, one thing is this is medulla oblongata because you see pyramid and olive, because you see inferior nucleus, this is anterior. Posteriorly, you see open medulla. So medulla has two parts, upper half of medulla, lower half of medulla. Upper half is open, lower half is closed. If it is closed, you will have a central canal, but there is no central canal here. It is related with fourth ventricle here. So this is open. So if it is open medulla, not the closed, and if it is upper medulla, anyway, lateral medulla. So lateral medulla, Wallenberg syndrome and all that. So if it is lateral medullary syndrome, Wallenberg syndrome, pica occlusion, but there was no pica in the option. And moreover, Harrison medicine says the Wallenberg syndrome is mostly due to occlusion of vertebral artery. So pica itself is a branch of vertebral artery. So it won't be very good to answer it as vertebral artery, because if they are asking which is the artery supplying lateral medulla, I will always say pica. But if pica is not there, then I will say vertebral artery. So I think somehow they gave you such a question where pica was not there. Posterior inferior cerebellar artery was not there. So in that case, you will take your answer. Means in such a question, your answer should be pica, preferred over vertebral artery. But then if they ask you, Wallenberg syndrome is due to occlusion of reverse. Wallenberg syndrome is due to occlusion of, if both the options are there, then Harrison medicine says Wallenberg syndrome, most cases are due to occlusion of ipsilateral vertebral artery. Remainder cases are pica occlusion. So be careful. If they ask you which artery supply here, first answer should be pica, not found. Then you take your answer as vertebral artery. I hope you got my point. See, the entire motto of this discussion is examiner is smart and he thinks that you are dumb, which is a fact. Actually, we are dumb in relation to his knowledge and experience. These people are some 70-year-old anatomy professor. So we are dumb for them. Obviously, even I am dumb for him because I'm 20 years younger and you are still 30 years younger to my experience. So we are dumb people for them. They are wise people comparatively. So they'll try to trick us and we will not be, getting into their trick. We have to escape. We have to learn way out. So how do you learn the way out? By practicing more and more of MCQs. Here your answer should be vertebral artery. Not needed. Okay, what about this? Again, nothing new here, but they keep on changing the H-shaped suture, you see, H-shaped suture. The pterion. So pterion, what is deep to that? Everybody will say anterior division of middle meningeal artery, epidural hemorrhage and all that. So pterion H-shaped suture. And it is anterior division of middle meningeal artery, extradural hemorrhage. That is what we learn. But there is one more thing. Deep to that is the stem of the lateral sulcus in cerebrum. Lateral sulcus in stem of the lateral sulcus. Beginning of the lateral sulcus. Choice C should be your answer. I'll show a diagram. One other thing they can ask you is, which fontanelle is here? That fontanelle is called sphenoidal fontanelle. Why it is called sphenoidal fontanelle? Because it is related with greater wing of sphenoid. This is the greater wing of sphenoid. So that is why sphenoidal. This is greater wing of sphenoid. This is frontal bone. This is parietal bone. Inferiorly temporal bone. The four bones: temporal, parietal, frontal, greater wing of sphenoid. Sphenoidal fontanelle. So they'll ask you, sphenoidal fontanelle closes at which age? Post-birth. These are all questions and they'll keep coming. So tell me, sphenoidal fontanelle closes at which age? Normally the books will say 2 months. But if 2 months is not given, take it as 6 months. Some books will say 6 months. So remember, when a baby is born, there's open membrane here. Open skull sutures are not joined. The coronal suture has not joined with squamosal suture. So there'll be some membrane here. You can just feel very small, like not as large as anterior fontanelle, but there is a fontanelle, and it'll close by 2 months. If 2 months is not given, 6 months. First answer 2 months, second answer 6 months. Some babies may have this persistent till 6 months. These are all MCQs. Okay, parietal sulcus was there. Parietal sulcus. So, but anyway, whichever sulcus was there, you will have only one answer. See, this is again the pterion. And if you look at the cerebrum, let us draw the cerebrum. This is cerebrum. So you'll have a central sulcus running anterior inferior. This is central sulcus running anterior inferior. And then you'll have a lateral sulcus. This is the lateral sulcus. This is the lateral sulcus. So pterion is somewhere here. Stem of the lateral sulcus. Let me change the color. That will be better. Say this color. This is lateral sulcus. This is lateral sulcus. So that is the pterion. Stem of lateral sulcus. This is lateral sulcus. Okay. Was this a question? Question with options: lateral, parietal, medial, all. I'll find out some of other questions we have, because it was only one day in hand, so I could gather some of them. Some questions are still pending, I understand. Okay, so I think they have very frequently asked such questions now. To tell you, in year 2004, AIMS, my PG clearing exam. Year 2004 AIMS Delhi, when I was giving my final exam to clear my PG, means the PG seat would be, I will be rewarded with becoming a SR from JR. The examiner gave us some transverse sections and were asking us, that time it was some new trend basically, but now this trend is no more new. They ask you even the undergraduates. Those days it was a topic for postgraduates basically, though we used to teach undergraduates. Anyway, so what we are looking at? See, here, let me tell you, this is the vertebra. This is the spine posteriorly, the transverse process. So vertebral body, spine, the transverse process of the vertebra. Inside is spinal cord. That is the spinal cord here. In front of the vertebra, and you can also see the lungs. You can show the lungs. These are lungs basically. Fissure is also seen. This is lung. And let us assume, or rather than assuming, you should always know, like in CT scan, we always look from inferior to superior, inferior to superior. And if it is inferior to superior, then this must be the right side, and that must be the left side. So normally we teach also, like as you do in CT scan, inferior to superior. So this is right lung, and that is left lung. But still, you can correlate it by looking at the details. Like, do you see what is this structure here? This is in front of the vertebra, esophagus. And what is to the left side of esophagus, or left side of midline? So the left side of esophagus, left side of midline is descending thoracic aorta. If that is the descending thoracic aorta, And if this is the esophagus, then where is the ascending aorta? If this is the descending aorta is here. This is ascending aorta. Now, if that is ascending aorta, this is descending aorta, why did you say this is ascending aorta? Why not this one, like arch of aorta? Or why not this one? If this is the vertebra, that is esophagus, this is descending thoracic aorta, fine. You are in the thorax, lungs are there. So, okay, to the left side of midline. Aorta is to the left side of midline. Okay, descending aorta. But why that is ascending aorta? Why not this one? Because compare the wall. Compare the wall. I rub it off. Compare the wall. Thick, thin. So if it is thin, then who is this thin structure? This thin structure is the superior vena cava. This is superior vena cava. But if that is the superior vena cava, thin wall, vein is thin wall. And what about this thick one? That is ascending aorta. But why that is ascending aorta? Why not the arrow mark? No. But why? Why no? Because you have to look at the relation. Relation of what? See, the right ventricle sends pulmonary trunk and left ventricle sends ascending aorta. That is the relation. Right ventricle sends deoxygenated blood into pulmonary trunk and left ventricle sends ascending aorta, oxygenated blood like this. That is the relation. Pulmonary trunk is anterior, aorta is posterior. Pulmonary trunk is to the left, aorta is to the right. Aorta to the right. So aorta is posterior and right. Pulmonary trunk is anterior and left. Anyway, if you say this is pulmonary trunk, this is ascending aorta, then which vein is here? That is superior vena cava. So that superior vena cava is here. What is here? That is the ascending aorta. Will be still here, the pulmonary trunk. It is bifurcated. And a question came last time. What is the arrangement of structures at the hilum of lung anterior to posterior? What is the arrangement of structures at the hilum of lung anterior to posterior? Which is the thinnest vein? So pulmonary vein will be more anterior. Which is still thicker? Pulmonary artery. Which is the thickest? The bronchus. Can you see the bronchus here? Let me rub this off. Everything I'll rub off. And then let us talk about the bronchus. This is the bronchus. This is the right principal bronchus. Right principal bronchus. And that is the left principal bronchus. So once you see the bronchus, can you see that in front of that is the artery and in front of that is the vein? Pulmonary vein, pulmonary artery, and bronchus. Thin wall, thickest wall. Anterior to posterior came as a question. So pulmonary vein, pulmonary artery, and bronchus. Here also you can see. This is the pulmonary trunk, basically. This is the pulmonary trunk, as I'll use the same color. This is the pulmonary trunk. So this is the pulmonary trunk. That is the bronchus. And if you are talking about this structure, that is pulmonary veins. Pulmonary veins, most anterior, then pulmonary artery, sandwiched, and bronchus is posterior, anterior to posterior. This is the arrangement of structures at the hilum. Mitral valve cusp, yes. Subaortic curtain. I know that question came. Subaortic curtain, we'll work upon that. But anyway, what is the answer? This is the bifurcation of pulmonary trunk. This is the bifurcation of pulmonary trunk. That is your answer. It is below carina. Carina will be at a higher level. Carina will be at a higher level where you just see the bifurcation of the trachea. So this vertebra, which level should be this? This must be some T5 vertebral level, or maybe T6. So T5 is better because sternal angle of Louis bifurcation of pulmonary trunk. Sternal angle of Louis, bifurcation of pulmonary trunk. If it was T4-5, then you will have carina. But these are controversial topics, so I will not talk much about them because it's a short session. And so keep your answer as pulmonary trunk bifurcating into the right pulmonary artery and left pulmonary artery. Giving further branches. These are the branches, means this will be left pulmonary artery branches then. This is the bronchus. This is pulmonary artery branch. That is pulmonary vein. Okay, let us move on to this question. I never thought that these questions will become so frequent. But anyway, again, the thing is, it is nothing new. If you go through the previous year questions, especially last 15 to 20 years questions, especially AIMS and All India PG. AIMS and All India PG. Now you'll ask, so where do you find this All India PG and AIMS questions? Last 15 to 20 years. That is what you will find that in books. Like, I'm telling you, self-assessment and review of anatomy. But who has the time to read those books? That is another question. So things become more and more elaborate, and we just try to manage. Cannot recommend you to go so much in detail for anatomy itself. Means if you have to read such a book, then you should start reading from first year itself. Not first year, means after completing first year. First year is over, then you can start with such books. If already you're MBBS, you have completed your MBBS, then you cannot go back. Then you have to just try to manage with by dealing with all these previous year questions. Anyhow, what do you think is the answer? Pectoralis major. What is pectoralis major doing? You see, the muscle is here, crossing anterior to shoulder joint. Any muscle which will cross anterior to shoulder joint will pull the humerus close to the body. A double D adduction. And not only A double D adduction, but it will pull because origin is sternum. Insertion is humerus. It will pull and it will fold the shoulder joint, flexion. So pectoralis major origin, insertion. When the muscle is contracting, it will shorten. It will pull, flexion, shoulder flexion. Now, if you say pectoralis major is for flexion, look for A2. There cannot be our answer immediately. So pectoralis major is for flexion. A2, these cannot be the answer. Now, B4, both of them B4. So we don't have to actually look at B, but anyway, look at B. Supraspinatus. We know supraspinatus is the initiator of abduction. So B4, yes, B4. Supraspinatus, 0 to 15 degree. But be careful. When you say supraspinatus is 0 to 15 degree, it doesn't mean that it will work only for 0 to 15. It works till 180 degree. All the muscles keep working in all the angles. So it is more prominently working 0 to 15 degree. So it is initiator of abductor. B4, no problem. Now you have to see whether C is 1 or C is 3. That will give you the answer. So infraspinatus. Infraspinatus is a muscle on the scapula, below the spine of scapula. Remember a simple rule. Any muscle which crosses the shoulder joint anteriorly will be doing medial rotation, turning the humerus inside. Any muscle which crosses shoulder joint anteriorly will pull the humerus inside. Medial rotator, like pectoralis major, accessory activity, medial rotation. But opposite will be a muscle which is posterior, outside, lateral rotator. So who is lateral rotator? The infraspinatus. If you say infraspinatus is a lateral rotator, means C is 3. Yes. So this is the answer. Yes. C is 3. And latissimus dorsi extension. Yes. Latissimus dorsi extension. So infraspinatus. See, I'll tell you simple thing. 0 to 15 degree supraspinatus. 15 to 90 degree deltoid. Lateral rotation by infraspinatus and further. This is abduction. 0 to 15 degrees supraspinatus, 15 to 90 degree deltoid, lateral rotation in first meatus and further. What is 90 to 180? 90 to 180 two muscles, the trapezius and serratus, overhead abduction. 90 to 180 overhead abduction, trapezius and serratus. What about the latissimus? Latissimus will help you scratch the back. Latissimus dorsi, lower back muscle. Lower back muscle, scratch the back, latissimus dorsi. So what I'm doing now, is it flexion or extension? Is it flexion or extension? Anyway, a muscle origin is here. Insertion is on humerus. What will do? It will pull it back, extension. And this test is also there. This test is also there. So a lot of details, but anyhow, it is a muscle of extension. Latissimus dorsi, lower back muscle, muscle of extension. Scratch the back using this muscle. Okay. Yes. Roy, the old gamer, the main palmate trunk is where we commonly see a saddle-shaped thrombus. Yes, good. Yeah, there was this aortic curtain, subaortic curtain. I had to work on that question. What about this? False about adrenal gland. Pure anatomy. Pure anatomy. Pure anatomy. किसको याद रहेगा ये सब क्या हो रहा है? ये क्या हो रहा है? Yellow in color, yeah. Tetrapattern, yes, of course, because this is kidney, front view, right kidney, left kidney. This front view, right kidney, left kidney, front view. Kidney, retroperitoneal. And adrenal is suprarenal. So it is also retroperitoneal, behind peritoneum. So kidney and suprarenal, they are retroperitoneal, as is the inferior vena cava. So inferior vena cava, abdominal aorta, inferior vena cava, kidneys, adrenals, ureter, retroperitoneal. So is it retroperitoneal? Yes, it is. Is the right adrenal concentric? No. That is the answer of exception. Yes. False statement. This is the answer. Why? Because crescent shape is left. So left is crescent shape. Yes. And what is right? Right is pyramid shape. And who will remember all that? I really doubt even the surgeons remember all that who are operating on adrenal. So this is read in first year and forget in first year only, but you cannot because there's an entrance exam. So right is at pyramidal and left is crescent shape. Yes. Okay. So left adrenal gland is present below spleen and tail of pancreas. Is correct. That is correct. How do you know it is correct? So this is a wrong statement basically, and that is your answer basically. Because it is not right adrenal, which is crescent. It is left adrenal, which is crescent. And right adrenal is pyramidal shape. So can you tell about choice D? Yes, you see here. You can see for yourself that this is from where we have removed the spleen. This is left side from where we have removed the spleen. And this pancreas tail was going into hilum of spleen. Tail of pancreas was going into hilum of spleen. So this is the pancreas, head, the neck, the body, and tail was going into hilum of spleen, and you have removed the spleen. Let us color the spleen like this. Are they related with the left adrenal gland? Yes. How do you know? Because I can see that this is the left kidney, and on the top of that, this is the semilunar adrenal. So that is the left kidney, yes. And it is retroperitoneal, yes. Even pancreas is retroperitoneal. Pancreas is retroperitoneal. And what is this here? This is the adrenal, semilunar adrenal. So adrenal gland is related with the tail of pancreas and spleen. Yes. Okay, fine. So we have to remember the relations. Yes. Remember pancreas, kidney, and the adrenal. They are retroperitoneal, but the spleen is intraperitoneal. It is covered by peritoneum all around. These other structures, retroperitoneal, means they are behind peritoneum, but the spleen is inside peritoneum. It will have ligaments suspending the spleen in peritoneal cavity. Splenorenal, gastrosplenic ligaments. So spleen is not retroperitoneal. Spleen is not retroperitoneal. Stomach is not retroperitoneal. But these structures are retroperitoneal. Okay. Mountain triangle shape. Okay, fine. Yeah, tell me. Again, these questions, these topics we continuously discuss. See, I'll answer this question. First, you look at some diagrams. Then you can see these diagrams. You are focusing upon this side, right side, anterior abdominal wall, right-sided inguinal canal, right-sided inguinal canal, right-sided anterior abdominal wall, which is the very first muscle forming anterior wall of inguinal canal. First of all, inguinal canal will have this structure coming with the testis. Testis, spermatic cord. So spermatic cord has to pass through inguinal canal. So whatever spermatic cord has relation, that is the relation of inguinal canal. Now, the spermatic cord, how does it come in the inguinal canal? By deep inguinal ring. And what is deep inguinal ring? It is a defect in the fascia transversalis. Fascia transversalis, deep inguinal ring. Now, spermatic cord was inside the abdomen. It has to come into the scrotum, passing inguinal canal. So deep inguinal ring is the opening in the fascia transversalis. How does it come out of the inguinal canal? It is an opening in the last muscle, external oblique muscle. External oblique muscle, this one. So this is superficial inguinal ring in the external oblique muscle. Yes. Superficial inguinal ring, the external oblique. The very first muscle, anterior wall of inguinal canal, is external oblique muscle. Now, if external oblique muscle is there, let us remove it from the anterior wall of inguinal canal. What is below that? Internal oblique. And what is internal oblique doing? You will see that the internal oblique muscle is anterior to the spermatic cord, roof of spermatic cord, and posterior to spermatic cord, arching fibers. If this is spermatic cord, anterior, roof, and posterior. Right side, this is spermatic cord. The internal obliques, external oblique is anterior, anterior, and anterior. Remove it. Internal oblique is anterior, roof, and posterior, arching fibers. So it is anterior, roof, and posterior. Posteriorly, it will be forming conjoint tendon. Posteriorly, it will be forming conjoint tendon, but it needs one more muscle for that. So that means external oblique muscle is only anterior wall. Yes. And internal oblique is anterior wall, roof, and posterior wall. Yes. Then what about the transversus abdominis? Transversus abdominis is not anterior. Transversus abdominis is not anterior. Then what it is? If this is the spermatic cord, it is not anterior. Then what it is? Roof and posterior. Roof and posterior. It is also arching fiber. It is also arching fiber, but not anterior. It is roof and posterior. And as it goes posterior, it will form conjoint tendon with the internal oblique. So conjoint tendon is two muscles. Internal oblique behind that, transverse abdominis. So again, what is external oblique? Anterior, anterior, anterior. Remove it. What is behind that? Internal oblique. What is internal oblique related to this spermatic cord like? Anterior, roof, and posterior. Anterior, roof, and posterior. And remove the internal oblique. What is behind that? Transverse abdominis. And what is transverse abdominis like? It is not interior. Then where it is? Roof and posterior. Roof and posterior. But when they go posterior, they form conjoint tendon. When they go posterior, they form conjoint tendon. Then if I ask you, both of them form the roof, you will say yes. Yes, and that will give you the answer to this question. Question is asking the fibers of internal oblique and transverse abdominis are contributing to which wall of inguinal canal? In the inguinal canal, you have spermatic cord, and they relate to spermatic cord. Both of them are roof and posterior wall. But when they reach the posterior wall, they are becoming conjoint tendon. So which is better answer? Roof. Now, in your exam, choices were there. A, B, C, D. Roof plus posterior wall. I think it was not like that. There was roof plus anterior wall, floor. So you had to choose. And I think the only option which you could have chosen, because there was no combination of roof plus posterior wall. The student told me there was nothing like roof plus posterior wall. So only option you could choose was only roof. What do you think? No, conjoint tendon don't form the roof. Conjoint tendon do not form the roof. Conjoint tendon formed once you reach posterior. Conjoint tendon will be formed once you reach posterior, not the roof. Conjoint tendon is not at the roof. It is posterior to the spermatic cord, posterior wall of inguinal canal. Roof plus anterior plus posterior. If you say roof plus anterior, transversus abdominis is not anterior to the spermatic cord. It is lateral to the spermatic cord. Transversus abdominis is not anterior. It is lateral to the spermatic cord. It is only roof and posterior. Only roof and posterior. So your answer can be roof or posterior. Posterior wall is by tendon. If tendon is not given, then you can say, okay, tendon formed by, conjoint tendon formed by transversus abdominis and the previous muscle, internal oblique. So basically, if this is the spermatic cord, inguinal canal, which is the muscle which is anterior, only that is external oblique. Remove it. What about internal oblique? Anterior, roof, and posterior. Posterior will form conjoint tendon. Remove it. Which is the deeper muscle? Transversus abdominis. Transversus abdominis is lateral, roof, and posterior. Lateral, roof, and posterior. That is roof and posterior. Posterior it will form conjoint tendon. And if you remove everything, then fascia transversalis, deep inguinal ring. Fascia transversalis, deep inguinal ring. First layer, external oblique. Second layer, internal oblique. Third layer, transversus. Fourth is fascia transversalis. I hope I made my point clear. What about this question? Tributary of inferior vena cava. So as you talk about tributaries of inferior vena cava, say this is the diaphragm, and this is the inferior vena cava, and this is the heart going into the heart, inferior vena cava. So this is the inferior vena cava formed by common iliac vein joining at L5 vertebra, lumbar 5. So common iliac vein in the pelvis cavity, common iliac vein in the pelvic cavity will join at L5 vertebra to form inferior vena cava. Inferior vena cava will puncture the central tendon of diaphragm at T8 vertebra, thoracic 8. Common iliac veins join in the pelvic cavity to form inferior vena cava at L5 vertebra. From L5 to T8 vertebra, it will be running. This is puncturing the central end of diaphragm to enter the right atrium of the heart. But before that, it will have tributaries. Now you'll see that in the abdomen, we have lumbar 3 and lumbar 4 arteries from both sides, L3, L4, lumbar arteries, L3, 4, draining into IVC, but not L1-2. Why not L1-2? Because L1-2, they are basically forming ascending lumbar vein. L1-2 forming ascending lumbar vein. So 1 and 2 do not drain into the IVC? No. So artery number 1 and 2, they join to form ascending lumbar vein. Right and left? Yes, right ascending lumbar vein, left ascending lumbar vein. It is lumbar 3, 4 in the abdomen, which will drain into IVC. So, is the ascending lumbar vein draining into IVC? No. If the ascending lumbar vein is not draining into IVC, then where it is draining? Ascending lumbar vein joins the, let us take some other color. Which one should we take? Let us take blue color. It joins the subcostal vein, rib number 12, subcostal vein. Below the rib number 12, below that is subcostal vein. It joins the subcostal vein, and together they form azygous vein. Azygous vein on the right side, and on the left side it will form hemiazygous vein, inferior hemiazygous vein. So once again, the lumbar artery 1-2 join and form ascending lumbar vein, which do not drain into IVC. It is joined by subcostal vein below 12th rib to form azygous vein, draining into superior vena cava, because body above diaphragm drain into superior vena cava with some exceptions. So what about the left side? Left side, lumbar 1-2 will join to form ascending lumbar vein, which will be then passing through the diaphragm, meeting the 12th rib vein, subcostal vein, forming inferior hemiazygous vein. But then inferior hemiazygous vein will drain into azygous vein, and azygous vein will drain into superior vena cava, because body above diaphragm drains into superior vena cava. So they don't drain into inferior vena cava. No. Okay, then what drains into inferior vena cava? Inferior vena cava, you have these inferior phrenic veins. Let us take some other color, this one. Inferior phrenic vein may be right or left. What is inferior phrenic vein? The diaphragm inferiorly. So right and left inferior phrenic vein, right and left both will drain into the IVC. Yes, this is IVC. This is the IVC. So you're telling that inferior vena cava will have right inferior phrenic vein, left inferior phrenic vein drain into it. Yes, and then one other thing which will give you the answer. If you say this is the inferior vena cava, this is right kidney, this is left kidney. Left renal vein, right renal vein. Right renal vein, left renal vein. Why have you shown left renal vein longer? Because this is inferior vena cava, which is right-sided embryologically. So inferior vena cava is to the right side of midline, abdominal aorta is to the left side of midline in the abdomen. In the abdomen, aorta is to the left and IVC is to the right. Why? Because embryologically, the left veins regress. So IVC is present only on the right side. If somebody is having double IVC, then you can have both of them. But normally left IVC disappears. If left IVC disappears, then IVC is where? On the right side. And because IVC is on the right side of midline, right renal vein is shorter, left renal vein is longer. That is why the gonads drain into IVC directly. The gonadal vein, maybe testicular or ovarian vein, So gonads, testis or ovary, testicle or ovarian vein directly drain into IVC, whereas the left gonad, left testis or left ovary drain into left renal vein, which then drain into IVC because they have to drain into IVC. So left testis or ovary, left gonads, the gonadal vein, left gonadal vein, drain into left renal vein, which then drain into IVC. Why don't they drain directly into IVC? Because far away. This is close, this is far away. So it drains here, then it drains here. Similarly, if you are talking about this semilunar gland, which is adrenal gland, the vein, adrenal vein, will drain into left renal vein and then into the IVC. Whereas this pyramidal shape, adrenal gland, drain directly into IVC. So adrenal vein drain into IVC on right side, but adrenal vein on the left drains into left renal vein, and then left renal vein drain into, or you can say the gonadal vein, adrenal vein drain into left renal vein, and then all the blood drain into IVC. This doesn't happen on the right side because they are close, so they can drain directly. So once you know this, there can be other clinical situations also. Don't want to go into those details, but you got your answer. So what is your answer? Tributary of inferior vena cava is inferior vena cava. So is it left gonadal vein? No, it was right gonadal vein. So is it right ascending lumbar vein? No, because if it is right ascending lumbar vein, it will be a tributary of azygous vein, superior vena cava, not inferior vena cava. Okay, so left renal vein, of course, left renal vein, it will drain. That is your answer. Left adrenal vein, no, because left adrenal vein drain into left renal vein. So the only possible answer is choice number 3. Okay, I think we should be stopping here. That is all I had, though I have other questions also with me, but maybe the faculty is waiting. I cannot encroach upon their times drastically. So it was all accept. It was all accept. How can it be? It cannot be. There can be only one answer in this question. There can be only one answer in this question. Is it multiple choice type? If it is multiple choice type, then maybe you will have fifth option also. But if you talk about inferior vena cava will drain the body below diaphragm. So it will have right and left inferior phrenic veins. It will have the 3 hepatic veins because liver is under diaphragm. Liver is under diaphragm. 3 hepatic veins draining into IVC. 3 hepatic veins draining into IVC. That is another tributary. So for IVC, what are the tributaries? Right and left inferior phrenic veins and 3 hepatic veins and right left renal vein and right left lumbar 3-4 arteries. Also, these are tributaries into inferior vena cava. Can I get all lectures in YouTube? YouTube पे सारे lectures तो possible नहीं है. Left phrenic vein. हाँ ठीक है. Left phrenic vein, left inferior phrenic vein होगा. Left inferior phrenic vein होगा. अगर left phrenic vein हुआ तो फिर तो superior भी हो सकती है. डायफ्राम के ऊपर भी हो सकती है. Inferior phrenic vein तो जाती ही है. I watched the session much calmly as I have not. Yes. जब तक हमने लड़ाई की प्रैक्टिस करना एक अलग बात है और लड़ाई के अंदर पहुंचना एक अलग बात है. Simulation is a different thing and the actual feel is a different thing. And we have been through the war. हमने तो दिए हुए हैं, एग्जाम दिए हुए हैं. और एक चीज और मैं आपको अभी मैं पते की बात बताता हूँ. कभी ये मत सोचना, कभी भी अपने आप को अंडर एस्टिमेट मत कर. अंडर कॉन्फिडेंस नहीं होना चाहिए. अंडर कॉन्फिडेंस, अंडर एस्टिमेट कभी मत कर. INI-CET एग्जाम देते हुए बहुत सारे बच्चे ये सोचते हैं कि हमारा होना तो है नहीं, चलो देते हैं, क्या पता. ऐसे नहीं. जब भी एग्जाम दो, ये आपको पता ही नहीं कब क्लिक कर जाए. और होगा ये, जैसे इस बार 4 सेशन हुए ना, 45-45 मिनट के. जब 2 आपके सेशन हो गए, तब आपको महसूस होगा, अरे मैं तो सारे आंसर कर रहा हूं. अरे यार चलो कर लो, क्या पता हो जाए, क्या पता हो जाए. आपको अंडर कॉन्फिडेंट नहीं रहना. आपको अपने को छोटा नहीं समझना. आपको पता नहीं है कब क्या चीज क्लिक कर जाए. ढीले में मत लेना कि 2 सेशन दे दिए ढीले और बाद में चले, अरे ये मैंने इतने आंसर मैंने कर दिए, क्या पता मेरा हो जाए. अब तो समय चला गया ना, तोड़ यहीं से लगाओ. हो ना हो, कर्म करो, फल की चिंता. बहुत बार ऐसा होता है कि आपका रैंक आ जाता है पर कम आता है, विच इज सो फ्रस्ट्रेटिंग. और ये मैंने अभी कहा आपसे, कर्म करो, फल की चिंता मत करो. ये पुरानी कहावत है. ये कृष्ण ने अर्जुन से कहा था, पुराना हो गया, गीता के सार को बदल दो, मेरा नया उपदेश सुनो. फल की चिंता करो, कर्म की नहीं. आई हैव चेंज्ड. गीता का सार, गीता का एक स्टेटमेंट बदल रहा हूं. मैंने अपने बेटे को बता दिया, कर्म की चिंता मत करो, फल की चिंता करो. कर्म तो तुम्हें झक मार के करना ही पड़ेगा. जब तुम फल की चिंता करोगे तो कर्म तो तुम्हें करना ही पड़ेगा. वो जमाने चले गए जब आप कर्म करते थे और सोचते थे चलो भगवान फल दे ही देगा. नो, तुम फल की चिंता करो, ऑटोमेटिकली कर्म तो होगा ही ना. अगेन एक चीज मैंने ये बदली, दूसरी ये मैंने ये बदली. लोग कहते थे प्रैक्टिस मेक्स अ मैन परफेक्ट. ठीक है, लेकिन बदल गया. परफेक्ट प्रैक्टिस मेक्स अ मैन परफेक्ट. सिर्फ प्रैक्टिस से नहीं होता. आप दीवार पे सर मारते रहोगे, कुछ नहीं होगा. दरवाजा ढूंढो, खिड़की ढूंढो. परफेक्ट प्रैक्टिस मेक्स अ मैन परफेक्ट. तो अब आपके लिए मैसेज क्या है? व्हाट इज परफेक्ट प्रैक्टिस? प्रैक्टिस एज मेनी MCQs एज पॉसिबल. और ये मत सोचो कि हर रोज तो 6 घंटे पढ़ ही रहा हूं ना, 6 घंटे पढ़ ही रहा हूं ना, भगवान कोई ना कोई रैंक दे ही देगा ना. रैंक तुम्हें लेना है, भगवान नहीं देगा. भगवान नहीं देगा. अपने अपने को अंडर कॉन्फिडेंट और ओवर कॉन्फिडेंट भी मत करो. प्योर कॉन्फिडेंस. It should not be underconfidence, it should not be overconfidence, it should be pure confidence. ठीक है भाई. All the best. अच्छे स्किलफुल डॉक्टर बनिए, हमारा यही मकसद है. एक तो एक एग्जाम आपको क्लियर करवाना है, पर उससे ज्यादा ये है आप अच्छे इंसान हो और अच्छे स्किलफुल डॉक्टर हो, ताकि पेशेंट आप पर भरोसा करे. ऑल द बेस्ट. टेक केयर.